And we would like to announce Vitaly Kushnir one more time from the Center of Human Reproduction, who will give us an insight on that recently approached practice on whether we should freeze all the eggs or rather proceed to fresh embryo transfer. Please, Vitaly.
Okay, slightly different subject, but close.
Sorry.
I'm talking about frozen donor eggs versus fresh donor eggs. And this is a very hot topic in our field, as you will see in just a minute. I have no relevant financial relationships to this particular talk or subject. So there is no question that oocyte cryopreservation has been a big breakthrough in our field. Probably since the advent of ICSI, this has probably become the major breakthrough in the field of reproductive medicine. It's really revolutionized the options that we have for women who are at risk for losing their ovarian function, as we discussed yesterday. It's given new options for fertility preservation, both for medical reasons and for social or elective reasons. It has enabled some patients to eliminate ethical concerns related to embryo cryopreservation. It solves the dilemma of abandoned frozen embryos in the IVF laboratory, and of course it's enabled the practice of oocyte donation, and that's mostly what we're going to focus this talk about today. So I think we're all familiar with this publication from our national society, the SRM, here in the United States. This came out at the end of, or at the beginning of 2013, and there were some studies that this recommendation was based upon, and I'll point out two of them here. Both came from Ana Cobo's group in Spain, and specifically these two studies were performed in oocyte donors. These were in infertile patients. So let's just focus on these two for just one moment. And the bottom line here is that they reported very high success rates per clinical pregnancy rates per transfer with vitrified oocytes. In this study, they reported 60%, and here 55%. And it's important to note that these were relatively small numbers of patients. Here there were 30 vitrification cycles, and here there was just a bit under 300. But this studies really led the lifting on the experimental label on oocyte cryopreservation. Although ASRM was very nuanced in their position, in that they said that specifically for the purpose of donation, they recommended that more widespread clinic-specific data on the safety and efficacy of oocyte cryopreservation in donor populations are needed before universal donor oocyte banking can be recommended. So they didn't actually lift the experimental label on that particular use of oocyte cryopreservation. But we all know what happened since. This is an article that came out in the Wall Street Journal recently, and it shows that, at least in the United States, the number of egg donation cycles has been steadily increasing every year, and the live birth rates are very good, as we know. They're around 50%, a little bit over 50%. So there's an increasing number of babies being born, and the other big development that's happened in the field is that a few years ago, a group of egg donors got together and they actually sued ASRM because ASRM had a position paper out, a practice guideline, which said that centers should not compensate donors above a certain amount, and I think the cap was at 8,000, which basically, at least in New York, everybody stuck to. So the donors made the argument in court in their lawsuit that this was anti-competitive, that their ability to garner wages was being restricted. Basically, they made the argument that ASRM was involved in racketeering. So ASRM very quickly backed off and decided to settle the lawsuit with these donors. And in the process of that, they removed this recommendation. Okay, in its place, they recently published an ethics position paper, which basically argues the same thing, but it's no longer a practice guideline. It's more of an ethics statement, and it basically puts the onus onto clinics and practitioners. But in effect, what this has done is it has led to the commodification of human eggs, and together with these two things have come together: the lifting of the payment and payment caps, and the emergence of egg banks that have now popped up all over the United States and internationally, has really put a price on human eggs. In the past, donors were compensated for their time and their effort. And all the oocytes they produced would go to the recipient. Whether they made 5 or 20, the recipient would have the same fees. But now the situation has changed because egg banks are selling eggs, per egg basically. They're charging, for 5 eggs you pay one price, for 8 eggs you pay another price. And so this has led to commodification of human eggs. And I'm not sure that our field is necessarily ready or has addressed all the ethical implications of this. What we've seen is that there is, the 4 E's are especially relevant here. Donors of rare ethnicities or ethnicities that are underrepresented in donor pools are in high demand and can now garner potentially higher payments. Donors with high levels of education, somebody who is in medical school, for example, will probably garner a much higher payment. Certain professions, and of course aesthetics. Everybody wants a donor who is a prettier and smarter and better version of themselves. Getting back to the actual technology. Probably the biggest data set comes from Ivy, which has been doing this for quite a while, and they recently reported their experience in their program with from 2007 through 2013. They performed almost 3,500 cycles, and what they report is an oocyte survival rate of 90%. Implantation of 39%, and a delivery rate per donation cycle of 39.1%. As you can see, that report is quite different from what I showed you in their earlier studies, which justified the SRM change in the labeling of oocyte donation. So these results are quite good, but they're not nearly as good as what was published in the earlier studies. This is also a very important Kaplan-Meier curve from this paper that basically shows what is the probability of a clinical live birth based on the number of oocytes consumed. And you can see that there's a very steep increase here between probably 10 to 20 oocytes, and it kind of levels off around 40. Not 100% get pregnant with everything, but it gets very close to that by the time you consume 40 eggs. So most programs in the United States are allocating, anywhere between 6 to 8 eggs per cycle. So that probably puts patients somewhere in, this part of the curve. So we were interested in this after this change in the position. SART and the CDC started tracking this and started reporting this. So we looked at this very quickly after that experimental label was lifted in 2013. And we published our findings here in JAMA. What you can see is that in the first year since the label was lifted, 20% of all initiated cycles already in the United States used frozen donor eggs rather than fresh. In other words, it took months for the egg banks to be up and running and basically start capturing a very, very large market share within egg donation field. In the two graphs here and here, we're basically showing the differences in live birth rates, and you can see that with fresh oocyte donation, both per recipient start and per transfer, the rates are a bit higher than they are with cryopreserved donor oocytes. The difference here was about what is that, 6%, something like that. Here it's closer to 10. Statistically, this was highly significantly different. Now, exactly why this is, we don't know. It could be related to the freezing and thawing of the eggs. It could be related to the fact that most of the donor banks don't give you all the eggs. They only give you a small cohort, maybe 6 eggs or 8 eggs. So, or it could be some other factor. So we really need to understand better why the clinical live birth rates are lower. And this is unadjusted data, so we didn't have patient-level data. There is a publication that just came out from the CDC where they attempted to replicate our study, but look at patient-level data and make adjustments for the age of the recipient, for example, for their underlying diagnosis, etc. They basically came to the same conclusion. For oocyte donation, they still found that the live birth rate was lower with frozen eggs. And they also reported that miscarriage rates were pretty similar between the two groups, which is an addition. So since that publication, more data has become available through SART. So here in this recent review, we summarized the data from 2014. So now we can see the whole trend from both in fresh and cryopreserved donor oocyte donation in the United States. And the first thing you'll see is that the live birth rate per embryo transfer with fresh oocytes has steadily increased in the United States. These are relatively small increases, but we have been getting better with frozen. With fresh. With frozen, it's going actually in the opposite direction. You can see that from 47% to 44% in 2014. And the number of cycles is obviously increasing rapidly here with frozen, while the fresh cycles are actually rapidly decreasing. So there's a rapid shift in our field from use of frozen eggs, from use of fresh eggs to use of frozen eggs in their place. As this is happening, the success rates with frozen are dropping, maybe because as it takes clinics some time to learn the technology, and there is probably a learning curve to this. But again, we need to understand this better and need to continue monitoring and see how how this is going to impact our patients in the end. So, what are the advantages and disadvantages of each procedure? So we'll start with fresh oocyte donation. And the advantage here is that it's the gold standard. It's been practiced since 1983. We have documented safety and efficacy data, and it offers patients the highest live birth rates, as I just showed you. But there are multiple disadvantages. It's complicated. The logistics of coordinating between the donor and the recipient can complicate things. The cost can be very high. It's a huge burden on the fertility center to maintain a pool of donors who are ready to donate, or you have to rely on an agency to help you recruit donors. This can create long waiting periods for recipients to be matched with the donor, and it can because in fresh cycles, oftentimes either the donor or the recipient or both have to travel long distances. It creates problems of medical tourism and cross-border tourism. With cryopreserved donation, there are a number of advantages and disadvantages as well, and these include simplified logistics, improved selection of donors, long-distance shipping. You can ship eggs from California to New York or vice versa. Lower cost per treatment cycle, and potentially improved safety due to ability to quarantine the eggs and retest the donors the same way as we do with sperm donation, although probably the improvements here are going to be minimal in the end, because unlike sperm leukocytes, which is leukocyte rich and has potential to transmit viruses, that's a lot less of a concern with eggs. The disadvantages is that most banks split the eggs into groups, and so the recipient usually receives a limited number of eggs, and the live birth rates are somewhat lower, as I discussed. There's also a tremendous variability in the freeze and thaw techniques, particularly when the eggs are frozen and thawed by different people or at different centers. For example, if the egg bank is in California and is then shipped and thawed by a different embryologist in New York, so there might be variability there, and that's a big issue. And finally, we don't know what the cost per live birth is with frozen eggs. And that's something that remains to be determined. So I'm not sure that the cost per live birth is lower. It might actually be higher. So next, I wanted to address the technical considerations and try to kind of show how all of this integrates together. So the first thing we have to recognize is that there has been a tremendous amount of extrapolation of data between different patient groups. For example, extrapolation from donors to infertility patients and vice versa in justifying a lot of this technology. Next, we'll talk a little bit about vitrification and slow freezing and open and closed systems and the emergence of automated systems, which seem to be coming on the field onto the field very rapidly now. And finally, I'll close with talking briefly about embryo selection techniques as they relate to this. This has now become a kind of a classic study that I've mentioned here before. This was done in infertility patients. There's no study of slow freezing versus vitrification in egg donors, but everybody has kind of assumed that vitrification is a superior technique, and basically, I don't think we're going to get a study. Everybody is vitrifying donor oocytes now. And it may be true that it's better, but actually we don't have data to show that. The next thing is the open versus closed systems, and there have been several randomized controlled studies of sibling donor oocytes to evaluate thaw survival rates. The reason that closed systems are desirable is that you have this theoretical, in open systems, you have this theoretical risk of cross-contamination of viruses. For example, if the patient is a carrier of hepatitis B or something like that, that the eggs that are vitrified in the same system can become affected, and then this can lead to transmission of the virus. It's more of a theoretical concern, I would say, but nevertheless, scaling of egg banks is going to drive adaptation of closed systems, and that's why there's been such an interest in developing closed systems for oocyte vitrification. And so this is one such study. They looked at sibling donor oocytes obtained from the same donor. Some underwent vitrification in an open system, some went into the closed system. They showed that thaw survival rates were slightly higher in the open system, 93 versus 90%, but very similar. Most embryology parameters were similar. I apologize for the small text in the table. And clinical pregnancy rate here was 36.5%. So again, considerably lower than what we see with fresh eggs. And there's several other studies. This is probably the most recent one that has come out. This study actually looked at fresh versus vitrified oocytes within a closed system. And again, this study showed that the main embryological parameters that they had that they saw were better with the fresh oocytes was blastulation rates and top quality blastocysts. These were significantly better with fresh rather than frozen. Other parameters were basically very similar. And they showed very similar pregnancy and delivery rates and similar miscarriage rates. So this suggests that that closed systems are here and that they're going to be rapidly adapted to practice. So this brings me to automated vitrification, and this is probably the next breakthrough, at least in my opinion, in the field, if it works. I haven't tested any of these systems in our lab, so I would be very interested to do that, but there are at least two that are out on the market now. The Gavi and the Fertile Safe system called the Sarah. These are very different. The Gavi only vitrifies, it doesn't warm. whereas this one both vitrifies and warms. And this uses a closed system using a little pod, whereas this one uses typical straws. The theoretical advantage of these is that it takes the human factor out of vitrification. You can vitrify in California, and I can use the same system here in New York to thaw the eggs. So it levels the playing field, and I think that if these systems work as promised, it will lead to very rapid scaling of egg banks. So this is something we need to watch. So the last thing I wanted to address is Dr. Barad's recent study on effects of PGS. And recently at the SRM, I heard several speakers speaking about egg donation, and they very strongly recommended adding PGS to your egg donation cycles because to improve success rates, to lower miscarriage rates, et cetera, et cetera. You've heard this throughout the conference today. This is the analysis that Dr. Barad and our group has performed, looking at effect of PGS in U.S. donor cycles, and this is fresh cycles, not frozen eggs. Okay, and what you see here is that we're showing cumulative rates here, looking at the initial fresh cycle and the subsequent frozen cycles, and you can see that with PGS in donor cycles over a very long period of time, the clinical results, the clinical live birth rates were worse, both in the initial cycle and when you look at cumulative cycles. So it decreases the efficiency of oocyte donation, and if you're starting with frozen eggs to further decrease the efficiency, which already has decreased efficiency, to further decrease it with PGS, I think is very risky, and I would really caution people in the audience from compounding freezing eggs, culturing to blastocyst, biopsying the embryo, refreezing the embryo. I think what you're going to see if you start doing this is that a lot of patients will not have a transfer after they go through all of this. So the key points, fresh oocyte donation should be viewed as the gold standard against which newer procedures such as cryopreserved donor oocytes are compared. Acceptable but somewhat lower live birth rates have been achieved with use of cryopreserved donated oocytes in comparison to fresh oocytes. Use of cryopreserved donated oocytes may significantly simplify logistics and lower the cost per treatment cycle, but whether they lower the cost per live birth is still unknown. Long-term follow-up studies on the health of children conceived from cryopreserved oocytes are still lacking, and if you guys have this data, I'd love to collaborate on it. Establishment of donor oocyte banks formalizes commodification of human oocytes and requires reassessment of basic ethical considerations and donor compensation that has been prevalent in our field for the past 30 years. Thank you.